Well, welcome everyone. We'll have a few more people join as we get underway, but thanks for being here. My name is Colin Kinner. I'm the creator of the COVID Safety for Schools course that many of you are already familiar with, and I'm really happy to be able to welcome you to the first in our webinar series. The topic for tonight is the importance of clean air in keeping children and teachers healthy in schools, something that's obviously vitally important right now as schools are dealing with the current viral soup of illnesses, which includes RSV, influenza, and of course, still COVID. This webinar sits alongside the COVID Safety for Schools course. That course is a free online resource for parents and school staff who want to learn more in depth about COVID and how to minimize the impact of all airborne viruses in schools. We'll say some more about that at the end of this session. There's been a huge response to this webinar. We've got school staff, education administrators, parents, other members of the community joining us. So thanks to all of you for committing the time. We know everyone's extremely busy, so we're going to try and keep this session brief and to time. So we'll wrap up the presentation within the hour as promised. But if there are any questions that we haven't got to within that time frame, we might let it run a little bit longer. We are recording this webinar and we'll share it on the website for anyone who wasn't able to join the whole thing live. Before we start, I'd like to acknowledge the traditional owners of the lands on which we're meeting tonight and pay my respects to elders past and present. I'm delighted to be able to introduce our presenter for tonight, Dr. Greg Kelly. Dr. Kelly is a pediatric intensive care specialist and a pediatrician. He has extensive training and experience in pediatrics and ICU at several hospitals here in Australia and also in Canada. Greg also has a wealth of experience in treating children with acute respiratory infections, and he's also well informed about the longer-term health risks that are associated with COVID. So he's extremely well qualified to talk to us about tonight's topic. So Greg, I might hand over to you to talk. We're going to talk for, say, 30 or 40 minutes and then make sure we leave some time for Q&A from participants. If you do have a question, can you please type it in the Q&A? You'll see in your Zoom window, there's a Q&A button at the bottom of your screen. So if you can type your question, I will do my best to send some of them Greg's way at the end, and we'll get to as many as we can.
Thanks, Colin. Hi, everyone. Thanks so much for joining and for giving your time on this Wednesday night. So I'd like to acknowledge that I'm dialing in from Gadigal land here in Sydney, Australia. And I'm going to share my screen and hope that this works. Let's see. All right. Share PowerPoint. How's that, Colin? Is that working? Excellent. All right, so just a little bit about me to start with. So I trained, initially did a Bachelor of Medical Science in Infectious Diseases. I did my medical training in Melbourne and then pediatric training at the Children's Hospital in Melbourne, Paediatric ICU there as well. As Colin said, I've worked and work at the 3 largest children's ICUs in Australia and the largest in Canada. My daily clinical work is in the Paediatric ICU. So I have a skewed view in some ways, and in other ways I'm at the end of a very large funnel, and so we tend to see things potentially before other people see, because we see, for example, a third of the sick kids in the country at any given time. I'm not representing my hospital today, though they've been supportive of my work around COVID in the past, and I don't have any conflicts of interest. I'm not secretly going to try to sell you clean air at the end of this or anything. Other things, so in 2020, I got very concerned about the impact of COVID through my academic contacts in Italy and hearing about what was happening there. And so I led a group that organised 25,000 healthcare workers to sign a series of open letters. We got a huge amount of media around that. Then led a separate but related campaign to get our health authorities to recognise the airborne spread of COVID and to implement airborne level personal protective equipment for healthcare workers, which really dramatically reduced the rate of infections that our healthcare workers were getting, and thankfully avoided that sort of wave of healthcare worker infection and death, which happened in a lot of other countries. I've done some expert consultation with state education departments regarding COVID safety in schools, in particular around ventilation and indoor air quality. I've got a young child who attends daycare. Both my parents-in-law are primary school teachers, and so far I haven't had COVID. So whether those things count as qualifications or not. All right, so what we're going to cover quickly tonight, and it will be a bit of a whistle-stop tour, is COVID and other respiratory viruses, what they are and what they do to us, how they spread, reducing COVID transmission and disease, and with it, reducing the transmission of other respiratory viruses, assessing risk, and then how do we improve things both on a personal and system level. And finally, as Colin said, there'll be a bit of time for Q&A at the end. All right. So when we talk about we can talk about COVID or in a number of different ways, but it's essentially all the same thing. So the mainstream term is still COVID. SARS-CoV-2 or severe acute respiratory syndrome coronavirus 2 are all the same thing, and is the virus that causes the COVID disease. But COVID can also be used for the virus. That's totally fine, just in case we mix terminology up. Worldwide, these numbers I'm sure won't surprise you. 27 million is the low estimate for the number of people who've died. 65 million, again, low estimate. These numbers are very hard to pin down of people affected by long COVID, and a huge number of children who've lost at least one parent to COVID, and of course, many more who've lost grandparents or other loved ones. So the impact on children has been enormous. Australia should be proud that we've done relatively well on COVID relative to the size of our population. We've still lost a very large number of people, almost 25,000. We have a substantial number of people who are affected by long COVID, of course, and again, a substantial number of children who've lost a parent or grandparent to COVID. COVID is a top 10 cause of death around the world and in Australia for the last years that we have data, so 2022 and 2023. And it is a leading cause of death and disease for children. So in Australia, again, the last full year that we have data for, 58,000 children admitted to hospital, 5% of paediatric ICU admissions directly due to COVID, so 360 kids admitted to ICU, and 18 children, 0 to 19, died from COVID. We don't have comparable data for Australia, but in the US, in that period, it was the 8th leading cause of child death in the USA. I just want to talk about these numbers a little bit because I think there's been a huge amount of controversy around what numbers are and people using very imprecise terms. But children are not really meant to die from anything. And in Australia, child mortality is extraordinarily low. So every year in Australia, around 34 to 35 children die on the road across the entire country in the entire year. And there's about the same number of drownings. And when we think about the systems that we put in place to keep that low number very low, and then I think it actually illustrates something about COVID. So road death, far fewer children die than adults. Same with COVID. With COVID, we say that's a reason not to pay attention to children. With road death, we say that is a reason to pay attention. So there's a contrast there. We recognize that death is just the tip of the iceberg with road trauma. So of course, those 34 deaths are a tragedy, as of course, all the adults that die on the road. But there's a lot more injury, illness, people unable to work, people who take a long time to recover or never fully recover that we also need to pay attention to. Whereas with COVID, we've paid a lot of attention to death and not a lot of attention to the death and injury. We've got very broad political consensus about road deaths. So when the government, there's not a political party that says, we're not going to reduce road death. Everyone wants to reduce road death. And when new measures are announced, they have very broad community support. People might grumble about one or two things, but overall, we recognize that getting that low number even lower is a worthwhile thing to do. And of course, anyone that's got a young child recognizes the extraordinary efforts that we go to. You're not even allowed to take your baby home from the hospital if you don't have a car seat. We spend, if you're like me, you spend seemingly hours, but I'm sure it's not every day, struggling to get your toddler into the car seat and get the seatbelt on, and you make sure that it's properly fastened. And a lot of that cost is borne by the government, but a lot is also borne by individuals. We have collectively a huge community consensus around road safety. And the numbers are comparable to COVID, yet we haven't nearly got there with COVID. despite all of our wishes, I guess COVID hasn't gone away. We always have a large number of patients in hospital around the country, and then during the waves, it goes up. That hasn't decreased since we really relaxed the restrictions at the start of the Delta pandemic. We've had a stably high number of patients in hospital and corresponding stably unsustainable strain on our health systems. And I'm sure you're all familiar with those headlines from around the country, as well as the experience of trying to access healthcare. There's about 4 million or so infections per wave in Australia, which is 40 full MCGs. One of the more extraordinary things about a wave is that there's times when 1 million Australians have COVID at any given point, which is sort of at the peak of each wave. And I just find that absolutely extraordinary to think, and it shows how infective and how successful this virus has been and how far we have to go to control it better. The death is, of course, just one aspect, as we mentioned, and we know now that there's an increased short and long-term risk of cardiovascular disease, for example, heart attack and stroke and clotting problems, neurological disease, thinking and memory problems, some so-called brain fog, seizures, just a couple of examples. Immune and autoimmune diseases, immune dysfunction, other infections. There's been a well-documented rise in the rates of childhood diabetes or childhood onset type 1 diabetes after a COVID infection. We are absolutely seeing this in the ICU. So we're seeing we're not seeing all of this. This is UK data, but we are seeing a massive rise in things that we would normally see once per year. And there were times, certainly with invasive group A strep, we'd normally see 1 or 2 of them a year. We're seeing a couple per day. Enterovirus myocarditis, which is a severe form of a virus that affects the heart muscle. We've seen, none of us have ever seen so much in our lifetime or in the duration of our career. And that's just one of many. That experience is borne out around the world. So there does appear to be some effect on people's immunity that at this point out from the early pandemic clearly cannot be blamed on lockdown, despite how much people would want that to be. And of course, many of the kids that I see affected were not even born then, because we have predominantly babies and young children. Long COVID is of course, very important. It can affect kids and adults. The rates vary enormously depending on the definition. There are numerous symptoms: extreme fatigue, POTS, and so postural orthostatic tachycardia syndrome, a type of condition where people find it very hard to stand up because their regulation of their blood pressure and heart rate is very disturbed. Cognitive, meaning thinking impairment, memory loss, to name a few. Some of those symptoms improve over time for some people, however, many do not. And we also have a serious lack of understanding of the condition and lack of treatments. And it can be very hard for people to be taken seriously and very hard to access care in the current situation of many people not wanting this to be a real thing. When I said the rates of long COVID are disputed, it's one of the real probably distracting. There's a lot of distractions at the moment, but whenever, I think very few people deny the existence altogether of long COVID now, but we don't have good data on the true rates. We don't have perfect definitions yet. And so whenever anyone says, oh, the rate, for example, the WHO, the rate is 10%, there'll be someone who trots out and says, oh no, the rate's only 5%. Now, does that matter? Yes, it does a little bit, but the reality is that over a cumulative number of infections, your risk goes up with time. And so we're not talking about people getting infected once. We're talking about people getting infected once per year or once every 2 years. And so even if the rate was as low as 1%, that still over time becomes a serious concern, and it's probably not that low. So I'd encourage you not to get too distracted by people arguing over numbers which are not yet well defined, but to look at the cumulative lifetime risk. And at the moment, that's very significant. We know this is New Zealand data. New Zealand, obviously, extremely similar to Australia in very many ways. And school teachers, this was Freedom of Information data, school teachers had the highest rates of COVID infection. Not surprising when you look at the kind of environment that they're working in and the number of people that they're exposed to, and especially kids. All right. And then other respiratory viruses, as Colin mentioned, they are around. We test for 20 plus in hospitalized kids. There's the non-COVID coronaviruses. There seems to be a few of them around recently. Rhinovirus, the very creatively named nose virus. There's paraflu, 1, 2, and 3. We have adenovirus, etc., etc. We've had because we test for this panel, we sometimes find it's not uncommon to find 2 or 3 viruses, and occasionally we find 4 or 5 in one kid at one time. RSV is very important. It's the #1 cause for hospital and ICU admission for babies worldwide. We see very few deaths in Australia from that, but occasionally it can cause death without access to care or in someone who's got other pre-existing conditions, not unlike COVID. Influenza is an important cause of admission. It causes an occasional death in children, of course, remains very important. These viruses are a constant for daycare and school-age children. Most of them don't have long-term effects like COVID, but some might. There may be a slight increase in asthma risk with RSV, and EBV, or Epstein-Barr virus, has more recently been linked to multiple sclerosis development later in life. It's extremely likely, for reasons that we'll go through, that future pandemics will be respiratory. So in the same way that the last number of pandemics that we've worried about, SARS, the one we are currently worrying about, bird flu, are all predominantly respiratory viruses, and I'll explain the reasons for that. So it's important to remember that measures we take, sensible measures we take to protect us from COVID and other respiratory viruses, are likely to future-proof us to a degree against those other future pandemics. So it said that even though that influenza does remain an important condition, it's far outweighed by COVID in terms of deaths per year, as well as hospitalizations of children for influenza versus COVID. All right, so COVID and other viruses, how do they spread? I think sometimes it is just worth really going back to basics. And so viruses can't move by themselves. They're not alive. They're not even a cell. They don't have a brain. They don't have a muscle. So really, they rely on hacking our behavior. They can spread by multiple routes: water, air, mucous membranes, mother-to-child, skin, tongue, blood, by viral vectors, so animals, in other words. But over time, we've put controls over many of those routes. So we've reduced mosquitoes. We have clean water which comes into our house and sewage which is piped away. We have parameters around blood donation. So while all that's been happening, at the same time, we've moved as humans collectively to larger cities. We've moved indoors, both for work and play. We've got climate control. We've closed the windows, turned on the aircon, and we've improved energy efficiency, which means keeping those windows sealed shut. So what that's meant in practice is that it suppressed most routes that disease had to transmit, disease including viruses, whilst amplifying the airborne route. And that's the reason for this focus on airborne transmission at the moment. It's not because it's the only way that viruses can transmit, but it's because it's become the predominant way in our current situation when we've suppressed, effectively controlled so many other routes. So COVID is an airborne virus. We breathe out a range of size of particles called infectious respiratory particles, previously called droplets and aerosols, and then someone else breathes them in. That appears to be easily the predominant route for COVID. There may be a degree of transmission onto mucous membranes, someone coughing into your eye. Not that that happens that often unless you have a toddler, but airborne transmission, breathing it out, breathing it in, predominates with COVID. This science is a very contested, evolving space. So qualified people disagree. There's been a huge amount of bad, overly simplistic science done in the recent decades, and the newer studies are not done. I think very briefly, it is important to know the history of this because it still affects us today. But pre the 1900s, we thought that a lot of disease was transmitted by bad air, so-called miasma. And then we saw bacteria in water droplets with microscopes and that sort of thing. And we came up with this concept of droplet transmission for viruses as well. It was very incorrect and incomplete understanding of the physics, but it was extraordinarily persistent. These droplets were, thought to be big. They traveled only short distances and then fell to ground, which is why physical distancing and hand washing worked. And you could only get infected if you kind of touched one and put it in your eye or your mouth. Just as of the last couple of months, there's been a big change from the WHO that they're now referring to a spectrum of infectious respiratory particles, which range from fine particles, which we used to call these aerosols or are still aerosols, to bigger droplets. But recognizing that they exist on a spectrum and that drawing a line was both artificial and unhelpful, in fact, wrong. So while COVID appears overwhelmingly airborne, we actually don't know about a lot of these other viruses. You can go and look up RSV and flu, and you'll see a huge amount of literature saying it's airborne, it's droplet spread rather, but a lot of that's probably wrong. And it's likely that airborne transmission is important or very important for those other viruses too. It's likely that just as with many things in life, there's a spectrum, and it's likely that the relative importance of airborne versus other routes depends between different situations and different viruses. But my strong suspicion, having been one of the people who put up my head above the parapet about airborne transmission of COVID, is that airborne transmission will turn out to be important to very important for those other ones too. What I think is a stunning fact, a stunning related fact, is that during the years of, so the post-lockdown years of COVID restrictions in Australia, we showed that we could reduce these other viruses by an extraordinary amount. And so, prior to COVID, we'd regarded the common cold and winter respiratory viruses as a simple fact of life that we could do nothing about. But during those periods, so outside Victoria, there were very few lockdowns, and they were extraordinarily brief. But around the country, in fact, for my hospital, COVID and RSV had a 95 to 99% reduction. There was not a single flu death in Australia in 2021. And I think for most of you who are not probably medical or clinical scientists, it's important putting that into context. So we spend a huge amount of money. We produce hundreds of thousands of medical research studies around the world every year. And sorry, I'll just rewind there. And the vast majority are negative. So we spend tens of millions of dollars looking for a few percent reduction in something that we regard as highly significant. And most of the time it's negative anyway. So to demonstrate, not in theory, not in a small group of people, but at a population level, a whole country level, that we can have these staggering reductions in things that cost us, flu is estimated to cost us $500 million a year. And as I said, RSV is the #1 reason for babies to be admitted to hospital and ICU. So these are very important infections. We can almost eliminate them. And so the fact that we've then just stopped talking about the fact that we did that for a year or two, I find pretty staggering. So we know that measures to reduce COVID are highly likely to reduce those other respiratory viruses, and that will be very good for us as a community. We know that schools matter and that asymptomatic spread happens. Up to 70% of household COVID cases start with a school-age kid. Not a surprise to anyone on this webinar, I'm sure. Third of people with COVID don't develop symptoms but are still infectious, and quite a bit of spread, probably the majority, happens from those people because they're out and about. And in Australia, recent data, an infected kid will infect 1 to 2 other kids per class. And again, I think this comes down to how we present data. So the authors actually said, and that's nothing. Whereas I think, wow, that's pretty high. All right, so how does it spread? We talk about both short and long range transmission. Again, this is not an absolute absolute dichotomy. There's a range, but it's just a way to illustrate something. And if you're in that short range zone, the concentration of these infectious respiratory particles, aerosols / droplets, is extraordinarily high. It's very hard to limit transmission in that zone with anything other than masks. But once you get outside that zone, so if you're inside that zone, or of course, if you're distance, then you don't have that. Once you're outside that zone, you're more in the air's all mixed up and you're in the longer range transmission. And then a lot of these other measures that we're talking about will become effective. So reducing COVID transmission, as I said, very likely to apply to these other viruses that we haven't sorted all the science yet. We talk about layered mitigation. So we talk about this a lot in medicine as well. So when we test one thing in isolation, because we live and work in such complex systems, it's quite hard to prove that any one measure, for example, a HEPA filter or a mask or physical distancing or cohorting or anything like that, it's very hard to prove that it works in isolation. And even then, to truly prove that something works in medicine, we know takes many years. And then there's, on average, a 17-year time gap between proving that something works and implementation into daily practice. I don't know about you, but I don't still want to be thinking about COVID in 17 plus years time. So that's why we talk about bundles of interventions that collectively have an effect. And these are the interventions that I'll talk about here. And of course, we need communication to bring all them and go. Lower risk is not no risk. It is possible to achieve extremely low risk of COVID transmission with current technologies. It's possible to lower risk with current social political constraints. And of course, what's achievable in your context depends a lot on what your context is. What's achievable if we collectively tried? The Davos World Economic Forum is a good example. They tested all attendees and their pass was inactivated if they didn't test or they tested positive. They had drivers, masks, recognizing that transport is a high risk period. They tested the ventilation and improved air quality throughout the whole building, and they had HEPA and upper room UV air disinfection throughout the meeting. So that's possible, and all that technology is existing. That's probably not what a lot of us are going to be getting, but we can talk about how to improve things. Okay, so the first thing is physical distancing. It's not perfect, but it does get you out of that high range, short range transmission. Ventilation, natural ventilation. So natural ventilation can be good if it's good and can be terrible to non-existent and is highly variable between days. And we're talking about natural ventilation inside. Natural ventilation outside tends to be very good most of the time. So I'm talking about improving natural ventilation. If you have a room which opens on one side, that tends to be pretty poor. If you've got two openings, both either on the same side or at a 90-degree angle, then that's better. And if you've got so-called cross ventilation, then that is the best. As I mentioned, natural ventilation, highly variable. So if you're on a windy day and the weather's nice and the windows are open, great. Too hot or cold and everything's closed, it can be really terrible. / non-existent. So relying on that without testing is fairly problematic. Fans pointing outside can help to improve air exhaust and mixing, and ceiling fans can also help mix the air, which is also useful. Mechanical ventilation, how a lot of our buildings are ventilated, again, highly variable. The issue, well, a major issue, and there's many people around the world trying to change this, is that there's no minimum standards for buildings in Australia, or in fact, most of the world. There is for hospitals. They're mandated to have 6 air changes per hour at a minimum. Operating theatres are even higher. But for the majority of buildings, there's absolutely no minimum standard at all. They might be turned off or down. They could be set to recirculate rather than bringing in fresh air. And retrofitting old buildings can be expensive. So again, these can be, all of this can be tested, but it can be very hard to know what the mechanical ventilation system in your building is actually doing. CO2 monitoring can help with both of those things. And that's something that I'd encourage you to invest in a cheap one from Amazon. I think that's one of the single best things you can do to help understand the situation that you're in. and something that's small enough to fit in your pocket or handbag. So essentially, we all breathe out carbon dioxide. The atmosphere at the moment has about 400 parts per million. We continue to pump CO2 into the atmosphere, and that's going up slowly, but you've got your benchmark. And so if you're in a room with people, then the CO2 can give you it's really a rule of thumb. It's licking your thumb and putting it up to the wind, but an idea about how much you're breathing is other people's breath versus how much is fresh air. And you can get little tables like this. So if it's close to atmospheric, then you're breathing essentially fresh air at 800 parts per million, which is what we say is a decent high cutoff for a building. 600 is probably better. Then about 1% of the air you're breathing is rebreathed. Whereas when it gets up to 10,000, which things like buses occasionally do, then approximately a quarter of the air that you're breathing is coming out of someone else's lungs. And obviously the risk of COVID transmission and other viruses then is extraordinarily high. So yeah, just saying should ideally keep the levels below 600 and keep levels below 800. This is as I said, this is one of those practical things you can carry. And at this stage of the pandemic, it can be pretty grueling to try and keep sane and safe. And there are actually a lot of buildings, especially bigger ones, that have, like, for example, a swimming pool or a museum or art gallery that have really good ventilation. And so being comfortable and saying, well, I'm in here, this is actually pretty safe, can actually be a really positive thing. Without one of these monitors, you are flying blind because you're not going to ring up, or you're not going to be able to speak to the HVAC engineer for that building and find out what the air quality is, but you can just look at this at a glance and figure it out yourself. HEPA air purifiers and filtration. So they literally are just a very fine filter that filters out small particles. COVID is included in those small particles. Many schools have them. So all state schools in Victoria had them. I think New South Wales is definitely more variable. The cost per student per year is extremely modest. They really don't use very much power. They do have some obstacles to their being used. They can be noisy, especially at full volume, full power, which is when they're actually most effective. They're often turned off, down, or to auto. The problem with turning them to auto is that auto is really made for removing smoke from the air, and so they'll turn themselves up when they detect smoke, but not when they detect COVID. So they should always be set to the highest tolerable level. There are cost and equity concerns. As I said, the cost turns out to be pretty modest. There were equity concerns that if not everyone could have them, that no one should have them. That doesn't make a huge amount of sense. And just an important note that they don't change CO2 levels. So if you're in a very well-filtered space, the CO2 level might be higher than would otherwise be acceptable, but that would be okay. Upper room UV light disinfection, as used at Davos and by other wealthy people around the world. We know that when you really pack people in a classroom or a train, if you were to provide enough ventilation to prevent COVID, you'd need to almost be in a wind tunnel. And so it's extremely difficult to achieve with natural and mechanical ventilation and HEPA filtration alone. We know that upper room UV disinfection works alongside those things to supplement. It's not widely used yet, but it's likely to be important in the future. And importantly, it works against, not just COVID, but a range of viruses and probably some bacteria like tuberculosis as well. Not that that's a major problem in Australia currently. We know that cohorting can be, effective. This is really like a scheduling issue. So avoiding the mixing between groups and avoiding whole school gatherings and large indoor gatherings. Again, avoiding large indoor gatherings where the occasional super spreader event can happen. Masks and respirators. So they effectively turn. So this is really all that we use to look after COVID patients, and we have almost no staff infections. So we feel very confident putting on a fitted N95 and going, putting our heads in the mouths to do airway management of these patients who are coughing, and they're highly effective. They really, just a diagram of how much they reduce the amount of virus in the air there and really reduce that. As I said, these are one of the few things or the only thing really that if you're in that close range will reduce the risk of transmission meaningfully. We know they work in schools, but obviously they're, politically and socially difficult at the moment. Obviously, a P2 slash and N95s are substantially more effective than a surgical mask. If you're going to wear a mask, wear one of those. Teachers can be positive role models, obviously. And there are, still obviously some kids and teachers who are managing to do that, which is awesome. Testing and isolation, rats, I think they're not perfect. People know that, but it's important to understand what they're better at and what they're worse at. What they do still tend to be quite good at is testing whether someone is infectious. So not whether you've got any virus at all, whether you've got enough virus to actually be infectious. So that's still an important question to be answered in this. And of course, they're the tests that people can access now. And so we've got to work with the tools that we have. Most people are infectious for more than 8 days. So time-based return to school or symptom-based is not actually that effective. You should be testing even on a rat before you go back to a place where you could infect other people. So anyone who has had COVID should isolate until they're testing negative on a rat. Any line should be regarded as positive. But if you do test positive on a rat, you do have COVID and you are infectious. PCRs, you now need a referral from your doctor to get, so they're getting harder to access. They're very sensitive. They'll pick up any tiny amount of virus. They don't tell you when you stop being infectious because they can pick up virus for weeks afterwards. A rat will tell you when you stop being infectious. And of course, if you test negative on a rat, you may still have COVID. So if you're symptomatic or being exposed, you should test again or get a PCR if there's any doubt. How long are people infectious? On average, 3/4 for more than 5 days. 50% of people are still infectious at 8 days. This is one of these things about trying to apply averages to people. So when governments are saying, well, on average, people are infectious for 8 days, come out of isolation in 8 days. That means, well, half of people will still be infectious. By 10 days, most people have cleared it. There are documented cases out there of people who've been shedding virus for years now, people that are just unable to clear it. All right, skip over that bit. Vaccines. So COVID vaccines, we know they greatly reduce your risk of severe disease, hospitalization, and death. We know they don't prevent infection, do reduce it. They don't prevent transmission, again, do reduce it. And they don't prevent long COVID, but do reduce it. So they have an important role, but they're not everything, or they're not the panacea that we'd hope they would be. They certainly don't give permanent protection. It does wane over time. We know they're safe and effective. We've now obviously got huge numbers of people in the world who've had them. We've given 70 million doses so far in Australia. There were a number of adult deaths, most of them linked to the AstraZeneca vaccine, which is no longer available at all, and 0 deaths in children, compared to, as we said earlier, the very large number of deaths from COVID. We know that Australian adults are under-vaccinated. Australian kids are very under-vaccinated. The recommendations from ATAGI have recently become even more restrictive, and they're only recommending as an option vaccine for children and young people under 18 if they've got a medical condition. However, I think it's important just to understand that a little bit. So that's just a recommendation for a population level. A lot of the time in pediatrics, and in fact, in my practice, more than half of the drugs we use are not even licensed for use in children. But we make a informed decision that the risk is outweighed by the benefit in that situation. So your doctor has the option of recommending you for that vaccine. And in fact, unlike my situation where I'm giving off-label drugs to lots of children, there is actually an on-label, a licensed and available vaccine for children over 6 months in Australia. And if your doctor recommends that your child gets it with a full understanding of your circumstances, then that's available. In the same way that I could go and get a vaccine that is not recommended for routine use, but my doctor might recommend that for my particular circumstance, it would be useful. So that's an important thing to understand. Antivirals, if eligible, again, can have a role, again, can be hard to get and very expensive if you don't meet the criteria, about $1,000 for a course. All right. Just checking time. Yeah, we're doing well. So we talk about assessing risk. So that's a huge amount of information, but a really important thing to understand is that risk is not linear. So one fact I found particularly staggering early in the pandemic when we had such data was that half of COVID infections in Ireland, in this case, came from around 250 buildings, and there were estimated to be a couple of million buildings in Ireland at the time. So what that shows you is that risk is far from linear. There are a couple of situations, places that are far, far higher risk than others. If we can identify those and avoid or address them, then that's the low-hanging fruit. We're not going to be able to fix everything, but we can identify where we should be focusing our efforts. So risk and different risk factors interact. So we know that shorter duration is lower risk than a longer duration. We know that the more people, the higher risk. We know that the closer we are to those other people, the tighter people packed in, the higher risk. We know that ventilation, of course, matters. HEPA filtration and air disinfection, again, can reduce risk. Aerosol generating activity is what the people in that space are doing. So if they're sitting there quietly, like in a library, they're generating far fewer aerosols than if they're in a spin class or a choir practice. And again, we know that mask wearing and the number of people that are wearing masks and the quality of those masks can reduce risk. This is just a graph of how much we generate aerosols depending on our activity. So this is the sitting quietly in the library. Once you start talking, it goes up substantially. Singing, a lot of the early COVID outbreaks were in choirs. Playing a wind instrument, and then vigorous exercise can really get up there. Hence, lots of the COVID infections at the Tour de France, probably. So when we think about those risks, we then at schools can think about what the higher risk activities are going to be. So that'll be classrooms with poor ventilation, large indoor events, assemblies, concerts, buses. Buses are particularly high risk because vehicles in Australia seem to have extraordinarily poor fresh air from outside. Shared accommodation at camps and these indoor activities, singing, gym sports, and playing wind instruments. Medium risk activities, classrooms that are adequately ventilated that we're not having those activities, bathrooms and crowded outdoor gatherings. And then the lower risk activities, of course, outdoors when we're not closely packed, and classrooms with a lot of those layered mitigations in place. Just a very brief point that we do, of course, there's work health and safety in Australia, and we do have a duty of care to provide a safe environment for students, staff, and visitors. Of course, legislation differs between states and territories, but they're broadly similar. So what does this mean in practice? We do have to, schools, people who work at schools must inform themselves about risks in relation to COVID, which you're doing. We must be diligent about putting in place available and appropriate mitigations and take appropriate actions. And then we all have a responsibility for ensuring workplace safety at the places that we work at. All right. So the final bit, I just want to talk about improving things from my own perspective, having done quite a bit of activism around COVID early in the pandemic and continuing to work on improving things. But, you also working in your own place will have working or having kids at your own place will have a particularly local take on this. So I'll talk in quite general principles. There are reasons for optimism. So hopefully sterilizing vaccines, which will probably be squirted into our nose, are coming. There's certainly lots of work around it. There's hopefully a move to improving air quality regulations in buildings that should reduce not just COVID, but lots of other viruses and infections. There's UV light disinfection systems, which are showing promising. There's a couple of moves at governmental level recommending reducing these things. But right now, we are still in the thick of it and having to stick it out a bit. So at a personal level, just get in the habit of making a personal risk assessment of indoor, especially indoor, but all spaces and activities. It doesn't have to be particularly onerous. My partner and I say to each other, "Oh, that looks a bit COVID-y." Feel free to use that word. A CO2 monitor, as I said, can put a real layer of like data and sanity around otherwise what can just feel like a lot of guesswork. You can be proactive with your friends in suggesting outdoor and safer venues. Just say, hey, do you want to meet at the park? Or hey, I love this cafe. Happens to have outdoor tables. Of course, we should all be keeping sick kids home. If we've got HEPA, make sure it's on and at max. Test our kids with early symptoms to know what's affecting them. Buses are a particular risky time. So if you are able, then, dropping your kids off to the excursion and avoiding that bus can be really helpful. Take the vaccines that are available to you, and mentioned how you may be able to access some more. And as a general principle, do as much outdoor as possible. Sorry for those people in Wuchurewita, Tasmania. Obviously, the weather down there is not as good as elsewhere, but a lot of the country, we have really superb weather most of the time. Improving things at a systems level, definitely we're moving the needle rather than aiming for perfect. As I said, perfect or close to perfect is achievable with the technologies that currently exist. We're obviously far, far, far from perfect in a lot of the systems that we live, work, and play in. Doesn't matter how or why change happens as long as it happens. First thing you can really do is get informed. So this is the link to the resources that Colin has set up. So there's huge out there. There's longer courses. There's an hour course that they're working on developing. So really getting informed can be a really helpful thing. And I think they're doing amazing work. Find an opening or a message with broad support. So at the moment, about 50% of Australians think that COVID is a concern, and the other 50% think that it doesn't exist. My very scientific survey tells me that 100% of parents and teachers, if you speak to obviously parents at schools, think that other viruses are a concern. I am yet, honestly, I think, to meet a parent or a teacher who doesn't talk about viruses, especially in winter. So what I talk about is COVID and the flu. When I talk about meeting outside, I say, oh, there's a lot of COVID and the flu around at the moment. And then for the 50% of people who think that COVID is a concern, then they hear the COVID bit. And for the 50% of people that don't think it's a concern, then they hear flu. But find a message that you can get other people behind. Likewise, everyone wants kids to concentrate in school, and we know that once the CO2 level goes above 1,000 or 1,500, then concentration is impaired. That's another piece that you can use to get people to pay attention to air quality. Be opportunistic about when you progress things. So right now in the middle of winter, when everyone in the country seemingly has a sniffle or is recovering from the same, then that's a great opportunity to say, hey, can we do something about these virus transmissions? It seems like we have more. We do compared to the data from a few years ago. Can we do something about this? When we talk about moving the needle, it's obviously, be slightly facetious, but if you arrive at a school and the principal's got a unvaxxed and proud t-shirt, then it's going to be hard to move that needle, right? Whereas if you arrive at a school and they've got HEPA filters that were provided by the government, but they're turned off, well, that's going to be a much easier sell to just get them plugged back in and turned back on. So sometimes that means, if you have the privilege and the opportunity to do that, moving schools to or something, or moving classes to where you've got an easier sell, because we all only have limited time and energy, and we need to focus on the things that we can actually change. We can make it easy for people to show support. So, a very easy thing to do with current technology is to have a little link to a Google form. People can get that in a text message. And again, if you're latching on to a message that's already out there, so the principal said there's a lot of absenteeism, then say, hey, the principal has mentioned there's been a lot of absenteeism. Everyone's saying there's a lot of viruses. We have these air filters. We know that they might reduce virus transmission. Can we get them turned back on? Here's a link to a Google form to just say your name. you've got to think about a message that people can get behind. So there's a very there's a very valid argument that the viral transmission in schools is unsafe for people with disabilities. But if you start talking about human rights infringements and that kind of thing, then that's going to be hard for a lot of people to get behind. If you talk about virus reduction, that's going to be something that a lot of people can get behind. So really think about your messaging and getting those numbers up. Finding allies, of course, really important. If you're one person, then you're an annoying teacher or parent or annoying staff member. Whereas if you're 6 people, then you're a group of concerned citizens. Find leverage. There's a huge range of conflicting guidelines and recommendations out there from different departments. So find the one that supports the science and what you're trying to do. Make it easier by identifying barriers to change, and then actually, if you can, offering to do some of it yourself. So, for example, my workplace, I just said, these are the HEPA filters that we need for all of the offices and tea rooms. I'll go and get them. And my boss is like, great. And then, of course, we need to celebrate our wins. It's important to think as we come up to the end of time about psychological factors that because all of this information is out there, right? But why haven't we done more about it? And so understanding cognitive dissonance is very important. Essentially, what cognitive dissonance is when we have two conflicting ideas about ourselves in our minds, and it causes dissonance. So one is that we're good people, but then the conflict is that we've caused harm to ourselves and our loved ones by ignoring the risk of COVID. And so we hate that feeling in our minds, and we'll do many things to avoid it, but it's easier to actually ignore or make up facts than it is to accept that conflict at the heart of us. And so helping people to overcome that dissonance, and ways we can do that are by highlighting new information. So of course, a lot of this information has been out there for a while, but say, well, now that we know more things about the long-term damage that COVID can do, that can help. It can be one of the ways that can help people overcome cognitive dissonance. And really other reasons why we want to be very mild in our messaging, because once those defense mechanisms go up, it can be really hard. It can be really hard to lower them, and people will tend to dig in. All right. That is the end of my slides, and I'm going to stop sharing.
Thanks, Greg. While you're doing that, you covered a lot of good topics there, and no doubt there's a lot that, in this length of time we haven't been able to get to. So what I'm going to try and do is, in the time that we've got, just pull out a few questions that people have submitted, both when they registered for this and also live from people who are with us. So we'll start with some of the live ones. One of the first questions, it's come up from a few people actually, is what arguments can parents and teachers use with schools where they want to encourage the school to take more precautions to prevent COVID and other viruses spreading, but where the school is citing government guidelines? And as we know, varies quite a lot state by state, but overall, perhaps with the exception of Victoria, you've got government guidelines that talk about things like hand washing. And as you said earlier, COVID's an airborne virus, and hand washing may not be all that effective. Have you got any advice on how to overcome that kind of pointing to guidance and saying, well, the guidance says do A, B, and C, and we're doing A, B, and C?
Yeah, look, it's extraordinarily frustrating, no doubt. See, I think I sort of covered a little bit of this, but I think there's often conflicting guidance. So there might be, you can look at the education department, you've got the health department, their guidance will probably be slightly different. So choose the guidance that is more stringent to promote that. As I mentioned, people might be fingers in the ears, la la la, about COVID, but at this time of year, no one is fingers in their ear, la la la, about other viruses. So that's an opportunity to get people engaged. People are increasingly concerned about air pollution, bushfire smoke. When there's bushfires, there are other reasons for air filtration, and then everyone is concerned about kids concentrating at school. So, depending on your situation and what you've had previously, it might be, you might not be wanting to talk about COVID much at all, but you might be saying, hey, this is like at this level of air filtration, we know that kids aren't concentrating. Um, I don't know. Again, I don't know any school or any group of parents that says, "Oh, kids concentrate way too much in school." That's like everyone's concerned that kids aren't concentrating in school, that kids are dozing off, kids are getting viruses. These are all you've got to find the thing that enables you to progress the change and the messaging that's going to work in your situation. And it can be frustrating that it's not what we think of as the most important thing, but it's what might work for you at the time.
Hmm, thanks. There's another question that again has come up from a number of people is around vaccines for kids. You mentioned
Hmm.
before that getting kids vaccinated has become more difficult because there are some hurdles to getting young kids vaccinated
Yeah.
or for that matter boosted. So the questions, I guess, are getting to the point of what are the downsides from vaccination? Are there risks for kids? Is that why kids aren't being recommended vaccines, or are there other reasons that are influencing those decisions?
Um, I don't. I mean, I have some ideas about why kids are not being recommended for vaccines. It seems incongruous vaccination with our approach to other vaccine preventable diseases in Australia. Um, Certainly, there are, and we've had extraordinary success with our vaccine program in Australia, but many of the diseases in the schedule we literally never see. Or I've seen tetanus once in my career. Um, Fantastic. I haven't seen pertussis case for years. I've never seen diphtheria. So it seems incongruous that we vaccinate for these, and we should, for these things that are very rare, but we're not vaccinating for COVID, which is very common. Um, the it we know, as I said, there were some concerns obviously about the AstraZeneca vaccine now withdrawn. The available vaccines have been studied in huge numbers of kids, so they are safe. Again, they're not perfect. They don't prevent infection or transmission, but they do have some benefit. So I certainly and my many of my colleagues in the pediatric ICU community would love to see those vaccines being made more available rather than less available for children in Australia.
Thanks for that. Another question that again has come up from several people is around mask wearing and the role of masks in schools.
Yep,
Obviously, a difficult topic, particularly for younger kids.
yep,
But when you've got kids that are at an age where they could wear a mask, at least for some of the time when they're indoors,
yep.
what's been your experience in terms of uh, getting past those kind of social objections that you referred to earlier around no one wants to wear them and we're not told that we have to, therefore people don't. Um, any advice on how to increase the level of mask wearing within a classroom or a school or any other context?
Yeah. So it's unfortunate how politicized the mask wearing has become, and lots of people who should have known better. So, and I really do worry about the next pandemic because, as I said, it's very likely to be respiratory, and then we've somehow thrown masks on this bin. So I think, look, a lot of masks are not that. A lot of masks are ugly. A white or a blue surgical mask is can be hard to wear. So the mask that you are wearing is far better than the perfect mask than you are not that you're not wearing. So fine, there are now black N95s or KN99s, which are quite a bit more attractive. There are lots of manufacturers which make again, they're not perfect, but KN95 or masks in lots of different patterns. So if you or your kid are happy to wear one of them, then that's better than I would say don't even worry about surgical masks. Like if you're wearing a mask, wear something definitely better than a surgical mask.
Yeah.
And
There's
wearing
a
a mask some of the time.
visualization in the COVID Safety for Schools course. There's a little visualization that shows how leaky surgical masks
Yeah.
are. So that I mean, they probably do something, but it's negligible.
Yeah. Yeah. And again, it's this layered mitigation. So wearing a mask some of the time at the times that you think are the highest risk, um, and that you're now informed about what will be the highest risk is better than wearing it none of the time. And again, they interact with those other mitigations. So, if you are in a really well ventilated, filtered space, then a KN95 mask is probably quite effective because it's going to cut down that short range transmission, and then the filtration and the ventilation deal with the other bits.
Yep. Question that's come up about schools and classrooms is around layouts of classrooms and things that could be done practically to improve social distancing, physical distancing. Is that something that's really feasible? I mean, obviously, if you've got younger kids, it gets a little trickier. Is that something that can have much impact?
Look, it depends, because it depends on the circumstance. But yeah, there's definitely huge numbers of things that could be done with smart layouts and smart scheduling to make, once we accept that this is a thing that's worth doing, to maximize the time between use of a classroom, to maximize the number of classes that are the first classroom in the day or the first classroom after a long use, to maximize the distance between people. So all these things are possible to do, and are likely. And again, none of them are going to be the panacea, but they all will have some effect. And the relative size of the effect depends on what else it is you're doing in your particular circumstance.
So related to that, a question that's come up from a couple of people is around things outside of school. So,
Mm.
infections have to come from somewhere. And
Yep.
so I think there are a couple of people asking, I think I'll paraphrase this, that, what are the highest risk things that families do outside of school where they should kind of do that risk assessment and say, well, how do I reduce the risk to my family of whether it's going to a restaurant or, I don't know,
Yep.
a
Yeah, I
cruise,
actually had these
bus
slides in.
trip?
I took them out because I was that was getting too long. But they're excellent questions. So you have to you've got to keep sane and do things as a family, right? And so using that risk assessment tool, and so then it's quite apparent. And then if you have your CO2 monitor, this will bear that out. That the really high risk things are indoors um, dining, so eating in a restaurant, going to a bar, anything where there's lots of people packed into a small place for a long time with poor ventilation is going to be bad. Flip side is there's quite a few things, and again, you can confirm this with your CO2 monitor, that are really pretty good. So swimming pools, tend to be huge ceilings, tiny number of people relative to the space, really good ventilation systems. The CO2 rarely gets above 500. Most art galleries and museums, again, especially during the week, if you have that option, if you've got younger children, fantastic air quality. Um, so anything where there's a cavernous space, not a lot of people, and good ventilation systems. Some modern buildings, especially ones that have been built since the pandemic, really have excellent ventilation. The CO2 rarely rises up. So I'd recommend, yeah, just getting in the habit of that simple risk assessment, and then using your CO2 monitor to kind of confirm it. There are online resources that talk about, or that give you data about the air quality of different places as well, in different cities around the world.
So a related question to that is about accessing healthcare.
Yep.
Um, we know that in many hospitals and other medical settings around Australia, there aren't a lot of staff wearing masks, and certainly there aren't a lot of patients typically
Mhm.
wearing masks. What's your advice for anyone who wants to access healthcare safely in terms of minimizing their risk of getting COVID while they're doing that?
Yeah. Yeah, I mean, I don't think there's any excuse for healthcare or acquired infections, especially when we know how dangerous they can be for patients. But that's the unfortunate reality. Indoor air quality in Australian hospitals is mandated to at least 6 air changes per hour, which is good. And so again, especially when there's lots of ventilation, one-way masking can be quite effective, um, because you remove that short range transmission for yourself, or reduce it depending on the quality of the mask, and then the good ventilation takes care of the rest. Um, Yeah, people shouldn't come to hospital and get COVID in hospital. That shouldn't happen in the same way that people shouldn't come to hospital and get MRSA. But even though we accept that they shouldn't get MRSA, we seemingly have not accepted that they shouldn't get COVID.
Yep. I think we've probably answered most of the questions. There are
Brilliant.
several that I'm going to refer people through to do the COVID Safety for Schools course because there's some technical detail on things like air changes per hour and CO2 levels that might trigger different types of action. So if I could take this opportunity to recommend that if anyone has questions that go into that sort of detail, the course, which is freely available on the website, and we'll circulate a link to it afterwards, goes into a lot of those things in plenty of detail. So that should answer all of those questions.
Yep.
Is there any, before we wrap up, Greg, is there anything else that we
I'm
haven't
just having
touched
a
on
bit
that
of a
you want to?
scroll through the questions. There was a question about the accuracy of CO2 monitor. If you're writing a report for the Intergovernmental Panel on Climate Change, important to be accurate. If you're just looking at, is this air clean or dirty, then, anything, the cheapest 4-star one off Amazon will be totally fine because you
Yep.
care if it's, 400 or 1400, not if
I've
it's,
got my handy one here. It says it's 900 and something, but it's
yeah,
only me in my home office, so
yeah,
that's okay.
yeah. Cool. Well, thanks
Okay.
so much, Colin, for having me, and thanks everyone for your attendance and enthusiasm.
Yep. Thanks very much, Greg. I'd also like just to, before we wrap up, acknowledge the support of CanRO, which is a philanthropic organization that supported us to help make these webinars and the course freely available to anyone who wants to access it. So that's been super helpful. And again, encourage anyone who wants to themselves or for their school or their community register to do the course because it will give you a whole lot more information on some of the topics that we've covered tonight. And thanks, everyone. We'll let you have the rest of your evening back.